stay on track. So a good chunk of our practice is related to colon cancer and colon cancer screening, detection, and interventions and therapy. It took a good chunk of our literature, time, and efforts. And we know from the National Polyp Study, that's where the whole story started, that an evolution from a normal colonoscopy to a polyp to cancer can take something around 10 to 15 years. And over the years, a number of landmark trials stated the intervention interval between screening colonoscopies, the effect of screening on the decreasing of incidence and mortality related to colon cancer screening. It's related to colon cancer if we perform screening. Even if you don't prevent cancer per se, just detecting cancer at an early stage can improve patients' outcomes. We know that if we detect cancer at an early stage, the survival is much, much better at 5 years compared to stage 4. And that goes without saying. How we detect and the options we have our classical stool-based studies, whether it be the old GOAC tests or the improved FIT test, which is the new standard of care. Imaging strategies looking at CT colonography, barium studies, and our usual gold standard colonoscopy. Newer modalities looking at DNA testing, other blood type of testing, looking at liquid biopsies, looking at proteins, mRNAs, and DNA testing are all coming into the market. They need more validation to even know their sensitivity, specificity, and their effectiveness. Over the years, it seems that our screening programs have made a dent in the mortality related to colon cancer. At least in the UK, over the years from 1995 up to 2015, there has been a significant reduction in both males and females. Globally, our target is early detection and prevention and reducing mortality and morbidity related to colon cancer. All of those targets are usually achieved if we implement a proper screening program, or at least we think so. Our classical programs, and some of us are still stuck in there with our FIT stool-based testing. Other programs looking at DNA markers and liquid biopsies are coming into the market. And in effect, over the last few years, the American guidelines dropped the screening age from initially 50 to 45 in special ethnic groups. Then they changed it to all over the board to start at 45. At least in Saudi Arabia, we started that a while back from 2015. How big is the problem? Well, on a global level, our region is not so hot when it comes to adjusted incidence of colon cancer. We're still in the lower spectrum of the incidence. And looking at the Gulf region per se, we're pretty low. We're not so bad. And on a global level, the incidence, we're in the lower third globally, at least the Middle East and North Africa. And when it comes to mortality, again, we're still on the lower spectrum. Same thing goes for the Gulf. And if you go into the mortality per se, we're in the lower quadrant. So it's not so bad. In the MENA region, from over 1990 to 2017, the adjusted standardized incidence rate is about 12. So it's not so high. We're talking about other countries in the 45 range. Although it's increasing, yes, by 39%. In Kuwait per se, it's about 10. Saudi Arabia is about 16 per thousand. And then that's almost like a 1.5-fold increase over the years. And Kuwait, again, is something like a 30% increase over the years. Although we'd like to think that colon cancer is the most important issue in our healthcare system, in reality, neoplasms only represent a small chunk. Cardiovascular disease remains the highest burden, and road traffic accidents are second. It comes in third place, at least in Saudi Arabia, when it comes to the life years lost, and it remains the first in males and third in females. And it starts around the age of 40. And I think we can think of it as the same thing for the whole Gulf. So let's agree that we need to look for these polyps and remove them as frequently as possible, as efficiently as possible. The AGA recommends a few tires. So the best thing would be a colonoscopy every 10 years, an annual FIT. At least that's what it's recommended in their guidelines. Tier 2 would go for imaging like CT colonography or a fit fecal DNA test every 3 years or a flex sigmoidoscopy. Capsule colonoscopy hasn't gained a lot of traction over the years. In the US, there are multiple guidelines, multiple interventions, multiple frequencies. It's all over the place. Asia Pacific and Europe also have their different guidelines. So when it comes to practicing colon cancer screening, there's a lot of variability, and it reflects the underlying population and the risk profile, the resources available, and the importance of the issue to the country. At least in the Gulf region, I think, at least from this document, that the first country to implement screening for colon cancer is Bahrain. And then after that, Emirat, after that, Kuwait, Lebanon, Qatar, and lastly, Saudi Arabia started in 2017 with a pilot project. Given the incidence that's low, we thought, well, we can do a cost-effective analysis and look if it's really worthwhile doing screening. We used the MyScan model, which is a pretty standard model for colon cancer screening. And we looked for 100, let's say for 1,000 men. If we do no screening, you spend nothing and you gain nothing. And then we looked at different screening strategies, either doing an annual fit every 2 years, screening colonoscopy every 10 years, or a once-in-a-lifetime colonoscopy. And for each of these dots, it represents a different starting age and stopping age. And it seems like a biannual fit is the most cost-effective per se. In our guideline, we chose a 10-year colonoscopy from 45 to 75, which is, yes, the most efficient. Sorry, it's not the efficient. It's the most effective, but it's the most costly, which is not the way to go. Even implementing such a strategy over the years, it would be costly in the beginning. It would decrease the cost over the years, but it's a significant budget for the healthcare sector. Comparing it to different cancers, and if we look at the cost-effectiveness threshold, at least in Saudi Arabia, colon cancer screening is the most cost-effective. So you'd gain more money, more life years for your money when colon cancer compared to breast. Cervical, lung, and prostate do not meet the thresholds, at least in Saudi Arabia. So this is the guideline we had about in 2015. We said starting at the age of 45, stopping at 70, just given that the age expectancy in our population isn't that high. We lean toward colonoscopy, sigmoidoscopy second, and fit testing or GOAC lastly. This was a study that looked at 2 hospitals screening colonoscopy for asymptomatic people. A good chunk found polyps. About 16% had adenomas, which is much, much less than what's reported in the West. And a few cancers, 1.6%. I'll share you through with the data with the pilot colon cancer screening program in Saudi Arabia. So they started from 45, stopped at 75. Both males and females were considered at regular risk. People at high risk were people who had previous polyps, family history of cancer, IBD, prior radiation as a child, and FAP. These would go for a colonoscopy directly. So the intervention would be a fit on an annual basis, and those at high risk or who have a positive fit would go for a colonoscopy. It would be done on an annual basis, the fit, and it would be performed in primary care centers. They even have a pathway for the patient, get seen by a physician for a test. The positive test would go for a screening colonoscopy. A negative test would be put on a second fit after a year. And it was very well planned. And what happens is, as Mike Tyson says, everybody has a good plan till they're punched in the face. So what happened? So over the years, from 2017 to 21, they rolled out the program. They got about 87,000 people invited. The invitation went well, but only half accepted to get screened, just above a half. Then a fraction of those had positive fit tests. A fraction of those who had a positive fit test went for a colonoscopy. And of those who had a colonoscopy, some had polyps, some had cancer. So you can see you start with a huge pool and you dwindle down to a small sliver of people really undergoing screening per se. There are multiple barriers, and the barriers are very well described in the literature. Some of it is fear, some of it is knowledge, some of it is perception of the risk. Is it applicable to the person himself or not? We tend to think that females are more acceptant of screening colonoscopies compared to males, and having the infrastructure per se to perform such a screening program. We tried to explore these barriers. We had an electronic survey for about just short of 6,000 people. We sent them a questionnaire using the health belief model. Do you think that you're at risk? What are the perceived consequences of such a disease? Do you think you have control over this disease? And we had very positive outcomes. So people want to get screened. They have no problems knowing about cancer. They think cancer is curable, and they think screening is important. We followed up with a very small question for the people in Riyadh, because we have control over Riyadh in our city. And the people who responded from Riyadh, we said, okay, you want to get screened? You're invited. And what happened is people who said, yes, I strongly agree to get screened, rejected the screening. They didn't come in. And those who were like on the fence, a good chunk of them refused. Those who didn't agree or disagree, the majority did not even accept. Which shows that it's not about knowledge. It's really taking that knowledge and moving it into action, and says a lot about what we can do about screening. So just planning something, and that's what we saw in the pilot project, doesn't make it successful. This was an interesting meta-analysis that people did not like, and it got a lot of bad letters to the editors. We worked on a few years. It took about a year and a half to work on. So it's a meta-analysis looking at different screening strategies, either doing a FIT every year, every 2 years, or a sigmoidoscopy or a colonoscopy compared to nothing. And there was a risk calculation for the person, what risk would they be at for colon cancer occurrence based on ethnicity, age, BMI, smoking status. And the last recommendation we found on this meta-analysis is that if your risk of getting colon cancer is less than 3% in the upcoming 15 years, screening for colon cancer is not recommended. If the risk is more than 3%, it would be recommended. Now, the evidence was shaky because there was no RCTs on the topic. It's all cohort studies, and they do have their own messiness with it. And the last recommendation was like, choose whatever option you want. It should be individualized, and it's based on the risk. Now, we always see the slogan, colorectal cancer screening saves lives. Interesting enough, people don't have trust in this, and they went for RCTs. And no talk about screening would be complete without talking about the recent Nordic trial. Now, it was a randomized RCT that gained a lot of press. It made it to CNN. It made it to multiple news outlets, and it didn't gain a lot of favorable reviews. People started making interviews about it and criticizing it to a very interesting degree. McMaster had a complete series of interviews, different specialties, weighing in on this trial, and people mocked it. So this was the title of the trial, Effective Colonoscopy Screening on Risk of Colorectal Cancer-Related Death, which is very straightforward. And people really didn't like it. So they said it's just mailing people, and this is really what you're testing. But it's a pragmatic trial. So it was an interesting RCT, 4 countries, Sweden, Norway, Netherlands, and Poland. It was a randomized trial, 2-to-1. People were invited to a single colonoscopy versus no colonoscopy. And they reported about 85,000 people. 10 years down the road, what happened? The primary outcome was the risk of colon cancer at 10 years, and there was a reduction with screening. Very minimal, but there was a reduction. The risk of colon cancer death did not change. There was no difference. They looked at secondary outcomes of death related to any cause, and there was no difference. So people did not like it, especially people in the US where screening colonoscopies is, I would caution to say, an industry per se, but anyway. But that's not the end of it. So there are a number of RCTs we should be seeing in the upcoming years. The Nordic was one that compared a single colonoscopy to no screening. We still have the confirmed trial from the US looking at colonoscopy to annual FIT, You have the Colon Prevent trial in Spain that looks at colonoscopy to a fit every 2 years. And then you have the randomized trial, the SCREESCO, looking at no screening, a fit every 2 years, and a colonoscopy. So these are going to be reported in the upcoming few years, and we'll see how it goes. Saudi Arabia still wants to go ahead with the screening program, despite their nice pilot project and the results they got. And they realize that when you want to implement a screening program, it's not the tool you use. It is understanding the population you have, having good registries, looking at the capacity, because when they looked at the analysis of their trial, they had supply issues with the fit tests. They have referral issues. People got positive tests and they couldn't get screened. So there's a lot of logistics in it. And you really have to engage the population. There has to be some media about colon cancer screening and its effect. Screening resources, rollout plans, we really have to be cautious about it. And if you don't have a quality program with the screening program, you're just burning money for nothing. With this, I think it's an interesting thing that, yes, you have a plan A and a plan B, but life is going to throw you some curveballs, and you just iterate as you go ahead with it. Thank you very much.